The fuck is up, YouTube? Fucking asshole, YouTube. Beautiful, muggy fucking day in New York. I just woke up from the vodka flu. And for your fearless, relentless leader, I guess I'm going to talk to you about something. That thing I'm going to talk to you about is Duloxetine. And what the fuck is Duloxetine? It's an SNRI antidepressant. It's developed by Eli Lilly. There's a newer version of it called desvenlafaxine. Sorry. It's Prestique. No, that's desvenlafaxine. That's Effexor, which is a totally different drug. Duloxetine. Duloxetine doesn't have actually any derivatives to it. It's just Cymbalta, straight up Cymbalta. It did go generic, so it's cheap. Being an SNRI, let's basically talk about how that works. So your brain conjures up images of neural synapses, and you see within these synapses there's a spacing in between every pair of neurons, and this basically at the macro level of many neurons being connected in a neural network, this causes the thing that we know as the neurological system, right? It's basically based on the spacing between axon and synapse, the relationship between that and the available quantity of what is being produced, what is being held in synapse, and what is diffusing through to the next neuron. So what an SNRI does is it is believed that serotonin plays a big role in major depressive disorder. A lot of people take Duloxetine for pain as well. Duloxetine. Let's think about that for a second. So Duloxetine has this special affinity for serotonin at various different levels and norepinephrine. It inhibits something that we call reuptake. Well, what is reuptake? Reuptake is the ability of the cell to reuptake back into the cell from the synapse and pass along neurological connections and signaling. So your brain fires off, and based on what's in the synapse, will tell the cell, what to take back in, what to pass along, what to leave in the synapse. And it is believed that the concentration in the synapse is very, very low. So through inhibition of reuptake, which is what the RI stands for, reuptake inhibitor, through inhibiting that, we can allow neurotransmitters to remain in synapse for extended periods of time, much longer, and we can sort of teach these cells to create new inhibitors, to inhibit it naturally. And this should theoretically deal with some symptoms of depression, anxiety, schizophrenia, all kinds of schizoaffective disorder, depression with psychotic symptoms, depression featuring bipolar, cyclothymia, many kinds of mental disorders are the theory currently, and it's a very, very well held one, a very well supported one, is that it has all to do with concentration in the synapse between axon, the neural head, and the synapse and the relationship thereof. So what are we basically doing? We are inhibiting this reuptake, so we're promoting a higher concentration of these neurotransmitters, serotonin and norepinephrine, without touching dopamine, even though serotonin has an affinity for dopamine at certain levels. That's why antidepressants don't make you feel very high or anything like that. And Duloxetine is very selective. It's a very selective one that almost leaves dopamine unhindered. Now, how does that work, considering that norepinephrine really comes from dopamine? Well, on the flip side, dopamine can cause symptoms like neuropathy, a pain pleasure, if you will. That's not really a great way to put it, but excitability. It's an excitatory neurotransmitter, very excitatory neurotransmitter, and it's an activating neurotransmitter, but not quite as peripherally as norepinephrine. And norepinephrine is kind of a bitch to control and can cause some symptoms when it's flooding into the synapse. It can cause symptoms of agitation, anxiety, increased heart rate, palpitations, targeted dyskinesia. In extreme cases, we're talking, but then we're talking like serotonin syndrome, which I guarantee you nobody really gets admitted to the hospital for serotonin syndrome. And SSRIs, SNRIs, DRIs, SNDRIs, NDRIs, doesn't matter what the hell the medicine is. The truth of the matter is that in general, it's just better to inhibit the reuptake of serotonin. And norepinephrine is also believed to play a critical role in anxiety because it's basically adrenaline. The name for norepinephrine, when it is a hormone and not a neurotransmitter, is noradrenaline. The two are not interchangeable terms. Noradrenaline specifically refers to the use of your body, the production of in your body of noradrenaline as a hormone throughout your body. Where it doubles as a neurotransmitter is when we start calling it norepinephrine. You understand? So norepinephrine in the brain, in the nervous system, noradrenaline hormonally. And as noradrenaline, it does cause some of the symptoms, like I just mentioned earlier, of agitation, anxiety, increased heart rate, palpitations, all kinds of weird shit. But this could also help with anxiety, because if it inhibits the uptake of norepinephrine, then it better regulates and controls the effects of anxiety, and particularly avoidant anxious people who have problems initiating eye contact or conversation or something like that, can highly benefit from better regulation, upregulation of higher concentration within the synapse. Certainly people with lower concentrations normally found, and there's no testing for any of this. There may be a couple of options that can indicate better, but these are for neurological patients that experience very severe nervous system diseases like Lou Gehrig's or something like that. They're not for people who, you don't need to go send everybody who has depression for a spinal tap or a brain CT, only under extreme circumstances. And even then, if you do take that into account, the nervous system does play a critical role in the behaviors that people undergo, but it is not the end-all solution. There are also environmental effects and implications and all these other things. So you got to take these all into account. And if you don't, then you're just kind of robbing somebody out of a potentially useful experience with their doctor and their medication. And a lot of people are very anxious to take medication. They're very, concerned about the side effects. Overlooking, of course, I always say that you're overlooking the potential benefits of medicine, and medicine does have the potential to really help you, especially if you're in a critical place in life. You should go see a doctor and not rely on psychotherapy alone. It's just not a wise decision. But of course, leave such implications to your doctor. That's more or less what's important. I'm going to chug this coffee. Now, thankfully, Duloxetine has a pretty relatively shorter half-life, certainly than Prozac, certainly than mirtazapine. Oh God, mirtazapine will stay in your system for weeks. You can detect it. It doesn't have as as short of a half-life in your system as Effexor, though. Side effects are still my comic joking name. Side Effexor is just a terrible drug. I don't even know why it's still on the market. It's basically like crack, crack in a freaking and as soon as you get off of it, you crash and you have suicidality, and patients experience terrible withdrawal symptoms. And Effexor is just not for everybody, and it's a little bit more discouraged. Duloxetine is a little similar to Effexor. To Effexor that is prescribed at 150 or higher, you start seeing it behave a little bit more like what Duloxetine is able to accomplish. Now, there are concerns of liver toxicity with Duloxetine. You shouldn't drink on it regularly. It's always wise not to drink on antidepressants, but if you want to have an alcoholic beverage and you're very moderate with it, maybe there would be no problem, but the FDA did bring down the recommended dosing due to concerns of liver toxicity. Down from 120 milligrams per day to 60 milligrams per day. And to be completely honest with you, I don't see as needing much more than 60 milligrams a day. And if 60 milligrams a day tops is not really doing it for you, there's possible supplemental treatment, but then that's a little bit more convoluted in that, you want ideally for a patient to be controlled under the minimal amount of medications. You don't want to start mixing everything up. It mixes well with lithium. It mixes well with, it's one of the few medicines that does not mix very well with valproic acid. It does mix, but lithium really mixes very well with everything. You also want to watch out when you're prescribing it with some of the dones and the dreaded enes. Quetiapine, which I don't even know why it's on the freaking market. Quetiapine is garbage. It's kiddie heroin, you get it in jail, and this is what keeps the inmates high for fucking days. Quetiapine or Seroquel, as it's known by its brand name, is pretty much garbage. You can take it very easily with trazodone if you're having trouble sleeping, and that's actually a really recommended course of treatment for anxiety with people with trouble sleeping. Another really good one may even be marijuana, which may have no interacting sort of properties to it. It certainly shouldn't depress from anything, and it might actually benefit the patient. So marijuana should be all right. Cocaine is a dangerous thing to take on Duloxetine because it's activating, and basically you'll start getting enhanced heart rate, and you could die. You could have heart murmurs and stuff like that. Though Duloxetine is not actually attributed very much with cardiac events, it is wise to watch out because it can raise your blood pressure, especially if you're on other medications. Other medications that might be found prescribed with Duloxetine might be some other type of antipsychotic, but then we're getting into the dones and penes, and haloperidol does not want to agree. I do not want to agree with this, but I do have to professionally agree with this. Haloperidol mixes well with Duloxetine, well-ish. Risperidone, no. Risperidone is one of the weirdest things. Don't take risperidone with Duloxetine. That is a dangerous psychiatric combination. You could get extrapyramidal effects, and the liver toxicity is overwhelming. Did you know risperidone is actually the toxic component of haloperidol, which is perfectly safe and has been used for years? Haloperidol has been studied. It's almost, although not recommended for pregnant women, where it can still be detected in the fetus and the mother's milk, but it's the least harm if the mother's trying to hurt herself, or she's trying to hurt the baby in any way. in admittance might be the least, along with palliative care. Certainly, should not be taken with other SSRIs. Absolutely not. You shouldn't be taking Paxil and Duloxetine. It mixes well with Adderall. There are a couple mixed reviews from that, where some people find the Adderall is now overstimulating, or Duloxetine sort of makes them feel all tired out, and they have to take more Adderall now. And it mixes incredibly poorly with Ritalin, because Ritalin in itself is a norepinephrine dopamine reuptake inhibitor. It's not a releasing agent, not nearly as powerful as Adderall, but it can be used supplementary for people who have anxiety issues with Adderall. It's been used pretty successfully myself. It helps quite a bit. It also helps prevent the oxidation of neurotransmitters a little bit prematurely in the prefrontal cortex. So it's been shown for actually really doing very good jobs with that. There's a lot that can be said about antidepressants, but Duloxetine, I like that one. I like Duloxetine. It actually has a benefit to the patient. Not very strong withdrawal symptoms. You might feel tired and cranky a few days upon withdrawal, but the dosing is so mediocre that you can really just sort of chill out and rest assured that Duloxetine is gonna be a safe enough medication, as long as you avoid things like alcohol or heroin or cocaine, crack cocaine, anything methamphetamines, unless of course you're taking prescribed. One of the few are taking prescribed methamphetamines for like sleep disorders or something like that. Even then you should be fine. There should be no reason for any severe interaction. Methamphetamine ultimately is just amphetamine. There's only very, very slight differences between methamphetamine and amphetamine, but only very few patients ever actually qualify for methamphetamine. It's more for sleep disorders than it is for like attention deficit or something like that. I don't like combining it with bupropion. There can be problems with bupropion, just like there are problems with Effexor. Bupropion honestly is a bit of a problem sort of medicine to begin with. Is highly overrated. Highly overrated medicine. You can combine it with anything. You can treat all these symptoms, sexual dysfunction, which is another thing Duloxetine might have a propensity to do. I haven't noticed that personally, but delayed and premature ejaculation for men, or anorgasmia for women. What else is new? I mean, in general, that wasn't very professional. I take that back, but there's a 17-minute video right now, so I just kind of gotta, wrap everything up. It might be very good for you. Might not be very well for treating people with alcoholism who have addictive tendencies, or it could be a godsend because it could be used in addition due to its more activating properties for people with who are coming hard off of cocaine or methamphetamine use or something like that. It could be. There's potential there for that. But I wouldn't stretch it too far, and I wouldn't worry about it. Talk to your doctor. That's what you should do. This is just an informative video, not a diagnostic video. Should not be used for diagnostic purposes in any way. This is just talk to your doctor. But Duloxetine is a good medicine. It also helps some people with pain, and I'm not in pain. I don't have pain disorder, but you have to speak to a pain specialist like that for that. All right, guys. Thank you all for watching this, and as always, I'll catch you in the next one. Peace.